This is the iFIT transtibial prosthetic device. It is a fully integrated modular system that is designed to work seamlessly with other prosthetic components and can be adjusted for persons with various limb shapes and sizes. The socket is a flexible socket that can accommodate most residual limbs. There is a soft inner liner which is velcroed into the socket. This allows for customization by putting additional padding into areas that might be uncomfortable or receive greater pressure. The buckles are custom designed and have a locking system so that they are safe after they close. They cannot open unless the safety button is pushed forward. The cable system consists of several lengths of steel cable which are covered by plastic. These thread through the cable guide in back and hook to the opposite side of the prosthesis. The cable system secures the residual limb in the prosthesis, and by varying the position, you can adjust the circumference of the prosthesis to tighten or loosen it. The socket is bolted to a cup, which houses a cylindrical shuttle lock that works with most commercially available pin suspension silicone liners. This lock can be interchanged with other cylindrical shuttle locks of similar height and circumference. A 4-hole pyramid adapter is bolted to the bottom of the cup. If the prosthesis needs to use an offset pyramid adapter, they can easily switch this out. These 4 bolts have Loctite applied to them, so be sure to reapply it if they are removed or changed. A standard pylon bonded adapter on one end and a clamp adapter on the other attaches to the pyramid adapter on the cup. Angular and rotational adjustments are made to the socket and foot similar to a conventional prosthesis. The 4-screw pyramid adapter at the base of the pylon works with most commercially available low-profile feet. When fitting the prosthesis, you only need a few hand tools. You need a pipe cutter to cut the pylon, a 4mm Allen wrench to adjust the foot and adapter near the socket. The screws on the socket use the same Allen wrench. They are screwed in with Loctite when the device is manufactured and not meant to be removed. To increase comfort for patients, we use a padding kit which can be placed over bony prominences or areas that are receiving high pressure. These pads can be cut accordingly. To finish the device, we use a torque wrench with a 4mm hex attachment to torque each bolt to the proper torque. We also use Loctite glue to secure all screws after their final adjustments. The patient must have certain clinical characteristics which will enable them to safely use this prosthesis. They must have good hand dexterity for opening and closing the buckles. They must demonstrate good judgment and be able to show that they can use the device safely. Patients must have no open wounds or skin irritations. They must have intact protective skin sensation. Their weight must be under 260 pounds, and they must have a strong contralateral limb and be able to ambulate at a K1 level or greater. This prosthesis is not a post-operative prosthesis. It is designed to be used on patients with well-healed limbs for when they would be put into a conventional socket. This can vary from patient to patient, but is generally several months. Depending upon the patient's residual limb length, you need spacers which will go inside the prosthesis. These come in 1 and 2 centimeter heights. The patient's residual limb must be 15 to 20 centimeters in length from the patella to the end to adequately fit this device. The maximum circumference can range from 22 to 36 centimeters. If using a device with a flap extender, these circumferences can go up to 42 centimeters. The iFIT prosthesis uses a soft neoprene liner, which should come inside the prosthesis when you receive it. If it needs to be replaced, it can be placed in the prosthesis so it reaches the bottom. Make sure it is smoothed and there are no wrinkles in the liner. The patient will place a silicone pin suspension system on their residual limb, which is sized according to the manufacturer's directions. The cable must then go through the cable guides on the back of the prosthesis. To estimate the pylon length, first have the patient put on the prosthesis without the pylon or foot. Have them then lie down on an examination table. Put the pylon onto the foot, align the base of the prosthetic foot with the base of the intact foot. You can then estimate where to cut the pylon. Draw a line where the pylon meets the pyramid adapter, go a little longer than you think might be necessary, as the limb may sink down into the prosthesis when standing. You can also measure the intact limb from the patella to the bottom of the foot, then measure the residual limb side from the patella to the end of the prosthesis. This will allow you to calculate how long the pylon and foot need to be. Once you have cut the pylon, you can deburr it so that the adapter clamp easily attaches to the pylon. Once the prosthesis is on, you can stand the patient to assess the height of the pylon and foot. This can be done by placing your hands on the patient's iliac crests. When ambulating, if the patient appears to be vaulting, this could be caused by either too long a pylon or an adjustment might be needed for the foot. The prosthesis is then aligned in a way that the conventional device is generally aligned. I align the prosthesis so that it is in a slightly valgus position with the foot in a slightly outward rotation. This stabilizes the knee when standing. Once they are walking, the dynamic alignment issues become evident. You can then make fine adjustments to the angle of the prosthesis, the angle of the foot, or the rotation of the pylon. By doing this several times, the optimal dynamic alignment can be achieved. Check that the pin is fully engaged in the lock before the patient attempts to stand. The patient should hear the pin click into the lock when engaged. Instruct the patient to attempt to pull the device off while sitting to make sure the pin is locked. The patient typically stands in the parallel bars or near a railing to make sure they are safe when first being fitted with the device. You then have them walk slowly with short steps. If there are any concerns, use a waist belt or contact guard. The liner is a uniquely customizable part of the prosthetic system. By adding extra padding over the tibia, you can increase comfort. If a patient has a thin limb, you can add additional padding to build up the neoprene liner. For persons with conical limb shapes, padding can be placed around the distal end of the liner. Any other high-pressure areas can use padding directly over the area or a donut to relieve the pressure. Once the prosthesis is properly aligned and the proper height is achieved, it can be finalized. To do this, the bolts need to be tightened to the proper torques according to the pylon manufacturer. Loctite glue is applied to the screws at the base of the foot and the base of the socket to ensure that they do not come out or become loose. Finally, we make sure that the amputee is fully able to use the prosthesis. They must demonstrate that they can put the prosthesis on and take it off. They must be able to walk with a safe and stable gait. If they use stairs at home, they should demonstrate walking up and down training stairs. Following the initial fitting, the amputee should be instructed to call you with any issues such as pain, skin irritation, or mechanical problems. Sometimes, they may need an adjustment to fine-tune the alignment after walking for a period of time. We like to follow up with our persons in 1 to 2 weeks after they have had a prosthesis. In this appointment, we check the mechanical aspects of the device, their skin, and the alignment. Thank you for watching this tutorial. If you have further questions about patient care, fitting this device, or any other questions, please visit our website at ifitprosthetics.com.